Welcome. In today's presentation, we want to look at and analyze the disparity and inequality of healthcare provided in the United States of America. This specific presentation is targeted towards radiographers and medical imaging professionals. The United States is a large and fragmented population. The distribution of healthcare resources is foundational to achieving fairness and having access to health services. In the United States, we currently have 5 social classes: the upper class, the middle class, the working class, working poor, and poverty level. We often discuss the shrinking middle class in America. As the population becomes more diverse, addressing healthcare disparities in the United States will become even more important. As a radiographer, you are primarily responsible for operating medical imaging modalities and interacting with patients and healthcare co-workers to produce high-quality diagnostic images that aid in the diagnosis of various patient conditions. A significant aspect of what a radiographer does revolves around preparing patients for procedures and then using their specialized knowledge and skills to perform the imaging exams to produce diagnostic images. The radiographers explain the imaging process to the patient, screen for any contraindication prior to doing the exam, help the patients prepare for the exam, and manipulate imaging equipment to get the desired image. As a radiologic technologist, you'll be responsible for several layers of communication with both patients and colleagues. Because there's not any single or specific type of person who might need health-related imaging, you'll be interacting with a broad and diverse cross-section of the population. Communication must be effective to optimize your interaction with patients. What does a radiographer or radiologic technologist do? Actually, it's a very complex job, and you're interacting with multiple people all throughout the day. You're comforting distressed patients, and you're consulting with physicians, explaining procedures, and also interacting with the patient to get the best quality examination possible. To do this, you have to have the patient cooperate with you. Radiographers have a very stressful job that can be emotionally draining. Very often they're interacting with patients that have serious trauma or are seriously or terminally ill. They have to interact with all kinds of patients on a daily basis, and they never know what is coming through the door next. Radiographers need to have a large picture of the overall health care provided within the United States to better ascertain how to do their job at their local facility. If we look at the United States per capita healthcare spending, it's almost twice the average of other wealthy countries. We're spending a lot more money, but are we getting better quality results? The answer is no. The World Health Organization says that we're a marvel as far as our technology and capabilities go, but when we rank ourselves in quality of health care compared to other countries, we rank number 38 in the world, right below Costa Rica. The manner in which we provide healthcare in the United States is very fractured. If we take a look at United States veterans and Native Americans, we have the VA and the Bureau of Indian Health Services. They provide healthcare very similar to the Britain's national health system. If we move from employer-employee relationships and health insurance, we have a system very similar to that in Germany. Once patients get Medicare, 65 and older, the healthcare system switches again and is very similar to the single-payer program that is offered in Canada. Unfortunately, about 50 million Americans are uninsured. Not only is our system fractured between federal and state providing health care, but also facilities within a state itself. If you look about, you will find that there are about 14 types of healthcare facilities where medical professionals provide health care. With diagnostic imaging, we include CT scans, ultrasounds, X-rays, MRIs, and other modalities that allow us to image the patient. While hospitals and even clinics have imaging centers, outpatient facilities help keep costs lower and allow more convenient scheduling for the patient. Of course, this does change the quality of health care provided. Hospital facilities will likely handle imaging for urgent cases such as an MRI for a brain injury or trauma. For radiographers, let's look at the 4 major types of facilities that you may work in. The first is a university or teaching hospital, a level 1 hospital. Level 1 trauma centers provide the highest level of trauma care to critically ill or injured patients. Seriously injured patients have an increased survival rate of 25% in comparison to those not treated at a level 1 center. To be a level 1 center, you usually have to be in a large metropolitan area. You must have all services available 24 hours a day and treat a minimum of 1,200 admissions or 240 major trauma patients per year. Here we see the Texas Medical Center in Houston, Texas. It's one of the largest medical centers in the world. Let's take a look at what facilities are available at the Texas Medical Center. Here we're going to see a good example in the disparity in healthcare available in different areas for patients and physicians and healthcare workers. We're looking at the medical center in downtown Houston. You'll note within a 20-minute walk there are 85 hospitals in that specific area with more than 19,000 beds. And these facilities employ more than 100,000 healthcare professionals, doctors, nurses, and all types of healthcare workers. In fact, they employ 7% of the total Houston area workforce. So you can see that if you lived in the Houston area, you would have access to some of the best hospitals in the world. We talked about level 1 trauma centers, and they're teaching hospitals and have all of the healthcare professionals and equipment available. Now let's take a look at a level 2 trauma center. A level 2 trauma center is very similar to a level 1 hospital, but we're not doing teaching or research. A level 2 trauma center has 24-hour coverage by in-hospital general trauma surgeon as well as an anesthesiologist. There are several minor differences between a level 1 and level 2 trauma center, but the main difference is that the level 2 trauma center does not have the research and publication requirements of a level 1 trauma center. Well, now, does everybody want to live in Houston, Texas? I don't think so. In fact, when we take a look at it, there's a lot of difference between metropolitan and rural areas. About 15% of all Americans live in rural areas, and they really do not have access to the same level of expertise and equipment and facilities that you would have in a metropolitan area. Rural Americans are a population group that experiences significant health disparities. Health disparities are differences in health status when compared to the population overall. And it's often characterized by indicators such as a higher incidence of disease and/or disability, increased mortality rates, lower life expectancies, and higher rates of pain and suffering. Very simple. They don't have the manpower, nor do they have the equipment to serve a major level 1 or level 2 function of a hospital for teaching or trauma. We also have level 3 and level 4 trauma centers. The level 3 trauma center would correspond to the 80-bed hospital in Sweetwater, Texas emergency room. Here you can get the patients in and stabilize them and then transport them to a level 1 when necessary. And it's often found in smaller cities and towns. The only requirement is that you must have services available 24 hours a day for emergency. A level 4 may or may not be a hospital, and they can stabilize and send to larger trauma centers if necessary. And these are usually in remote and rural areas, although we see a number of these popping up in metro areas as emergency clinics. Problems here are that you don't have all the equipment, you don't have all the different expertise and professionals available on site. You have to call people in, and what you find is that different people work on call nights and weekends. So what we're looking at here is this is for small traumas, small emergencies, things that are not going to be dangerous. If you take a patient that should be going to a minimum of a level 3 hospital to level 4, you may not get them there from the level 4 to the level 3 in time to save their life. Again, this is what we're talking about when we talk about response, the golden hour, etc. There are differences in every hospital and the type of services they can provide. So as we can see, the U.S. healthcare system is envied around the world, but despite having Affordable Care Act, the ACA, Medicare, Medicaid, etc., there's still significant disparity in access to adequate health care in the United States. And we're going to take a look at some of the factors that impact it. We just looked at the facilities, where the facilities are located, and if you do have access to them. Also, you're looking at the different populations. Populations change from area to area. We're also looking at the different socioeconomic groups per area and the ability to pay for services, whether it be insurance, Medicare, Medicaid, or cash. You'll find that there's about 50 million Americans who are not insured at this time. Even though we expend a large amount of money on services, those services are not equally distributed through healthcare facilities in the United States, as was obvious when we looked at the medical center in Houston compared to a small 80-bed hospital in Sweetwater, Texas. We always think that we have the best system in the world and that people are really being taken care of. In fact, we do a lot of charity work. Most U.S. hospitals are not-for-profit, and they get their not-for-profit tax exemptions by providing charity services to the population. That would be reduced costs or free health care for the poor, but it's actually a very small portion of what hospitals do. Let's take a look. Let's do a quick analysis of how these not-for-profit hospitals provide charity care. As you can see, charity care is a sliver of the hospital's total revenue. Hospitals in the United States that are not for profit in 2009 actually had a revenue totaling about $340 billion. Of that, the hospitals were given $15.6 billion in tax exemptions to be not-for-profit hospitals. How much did they really spend in total for charity? $7.5 billion. It's small even when other factors are considered, such as Medicare, Medicaid, charity, etc. And most hospitals fall in the low end of the spectrum in providing charity care and health care for the poor. This graphic shows some of the leading or most renowned hospitals in the United States, such as Stanford University Hospital or Cedars-Sinai. What we take a look at here is the net income of each one of these hospital centers and the tax exemptions in excess of charity care provided and how much charity care was provided. Notice for Cedars-Sinai that they had $16,123,766 that was provided to the poor or charity care, and yet their tax exemption was $104,327,297. Their net income or profits was $152,820,769. We can look down this list of these prestigious hospitals and see this story is repeated over and over again. Let's take a look at physicians around the world and physician fees, comparing physician fees around the world to the fees charged here in the United States. You'll notice in the United States, the lowest fee that a doctor receives is from Medicare. Their average fees are $2,000 plus up to $4,000 plus for each patient. Now we take a look at what they have for fees in different countries such as France, Canada, and the Netherlands, all of which have better health care by the World Health Organization than the United States. France is the #1 healthcare provider in quality in the world. Well, money's one thing, but how many physicians want to live on an Indian reservation out in the middle of nowhere in some rural town, as opposed to a nice practice at California on the beach in Los Angeles where they're making tons of money? Where do you think they're going to go? So again, we're just taking a look at the natural disparity available throughout the United States. It's not only the equipment, but it is the resources and the healthcare professionals that are available in each one of the areas. In this portion of the presentation, we're going to look at the United States government and how they impact or try to provide health care for the population of the United States. We'll take a look in just a couple minutes about the differences in health care provided by the federal government and the state governments. In the federal government, Human and Health Services, HHS, is the United States government's principal agency for protecting the health of all Americans and supporting the delivery of essential human services. HHS is committed to supporting the social and economic well-being of all Americans, including those individuals and populations at high risk of social and economic challenges. Prior to the 1960s, the federal government was not involved in healthcare insurance market. In the 1960s, President Johnson signed into effect Medicare and Medicaid, and it put more Americans on an insurance plan, and more employees had private insurance through their employers. Later, the federal government passed the Affordable Care Act. The Affordable Care Act is often referred to as Obamacare. And the Affordable Care Act has three primary goals. The first is to make affordable health insurance available to more people. That does not say all people, but more people. The second is to expand the Medicaid program to cover all adults with incomes below 130% of the poverty level. It also wants to support innovative medical care delivery methods designed to lower the costs of health care generally, however it is being provided. As we stated earlier with the Affordable Care Act, certain states may not recognize coverage or may limit its availability to their state population. This includes homeless and the poor. Here's a little Civics 101. What does the federal government have the power to do, and what does the state government have the power to do? The federal government has the power to make money, to declare war, to manage foreign relations, and oversee trade between states and with other countries. Conversely, the state governments have the ability to ratify amendments and manage public health and safety, as well as oversee trade in their own state. So there is a dichotomy between state and federal government and what they can do. If we pass a law such as American Care Act, or we pass Medicaid and Medicare, Medicare being a federal program for all, is universal. Medicaid is actually administered by the states, and it can vary from state to state. This presentation focuses on the national perspective and looks at Medicare, Medicaid, the Veterans Administration, the Affordable Care Act, and HHS. On a national level, these are fairly standardized, uniform healthcare support mechanisms. The unfortunate problem is that they're implemented by the state, and each and every state varies in how they implement these programs. Let's take a look at rural America. And when we're talking about rural America, we're talking about a different subculture within America, or a different group of Americans and how they live their lives. For risk factors for health disparities for rural populations, they are more geographically isolated. They have farther to get to different types of facilities and different types of amenities. On the whole, they usually have a lower socioeconomic status, such as if we look at Appalachia and the coal miners in Virginia, West Virginia. They also have higher rates of health risk behavior. What are we talking about there? We know that people that have lower socioeconomic standard do not have the money to afford preventative health care, nor do they have the money to afford the different types of foods or access to the different types of foods and diets that would indicate a healthy lifestyle. Remember, obesity is one of our big problems in America. This inequality is intensified as rural residents are less likely to have an employer-provided health insurance coverage, and if they are poor, they are often not covered even by Medicaid. Did you have the availability as an American citizen to go to any ER or emergency department prior to 1986 and receive care? No. The Emergency Medical Treatment and Labor Act guarantees a certain level of medical care to anyone who comes to the emergency department that accepts payments for Medicare or Medicaid. But a concierge hospital that does not accept Medicare or Medicaid does not have to accept you in their emergency department. Let's look at some other barriers to getting health care. Obviously, the first one would be lack of health insurance. Several racial, ethnic, and socioeconomic and other minority groups lack adequate health insurance compared with the majority of the population in the United States. These individuals are more likely to delay health care and go without the necessary health care or medication they should have been prescribed. Not only do they not have health insurance, they also have a lack of financial resources. It's very difficult for any of us to walk into an emergency room and just pull out a wad of hundreds and pay cash for services. Lack of available finance is a barrier to health care for many Americans, but access to health care is reduced most among minority populations because of the lack of financial resources. So therefore, racial and ethnic minorities are often given a health insurance plan that limits the number of services available to them, as well as a number of providers that they can use. Let's look at some more barriers. Irregular source of care. What is this? It is the ability to go to your regular doctor on a regular basis to get your medical care. Now, compared to white individuals in our society, ethnic or racial minorities are less likely to be able to visit the same doctor on a regular basis and tend to rely more on clinics and emergency rooms for their health care needs. Without a regular health care source, people have more difficulty obtaining prescriptions they may need and attending necessary appointments. For some, there are legal obstacles. Low-income immigrant groups are more likely to experience legal barriers. For example, insurance coverage through Medicaid is not available to immigrants who have been resident in the United States for less than 5 years. Another whole group of barriers are structural barriers. What are the examples of structural barriers? They're like, do you have the transportation to get to the doctor's office? Do you have the ability, time-wise, to be at the doctor's office and to stay there for your health care appointment? All of these factors reduce the likelihood of a person successfully making and keeping their health care appointments. Here's one we're all familiar with. Working in a hospital for many, many years is red tape. Bureaucracy is a problem in the healthcare industry, period. Communication is a problem in the healthcare industry, period. So in many communities, the emergency department or the emergency room is the only setting without financial barriers or the only setting that does not require an appointment. And it is also possibly the only setting that you can be seen that is open nights and weekends. Also, there is more of a possibility of someone in the emergency department being able to speak a second language or having interpreters available. A lot of the staff or interpreters speak Spanish, Hindi, or Cantonese. In fact, using the emergency department for many populations is in many ways easier than negotiating the complex bureaucracies involved in the rest of the healthcare system. The elderly also suffer tremendous barricades in getting health care. Older patients are often living on a fixed income and cannot afford to pay for their health care. They're more likely to experience transportation problems or suffer from a lack of mobility. With 15% of the older adults in the U.S. not having access to the internet, these individuals are less likely to benefit from valuable healthcare information on the internet or from doing telehealth visits. So again, another group that we have disparity in providing healthcare for is the elderly. Americans often figure that they're the only culture in the world and that English is the only language in the world. Interestingly enough, most of the world is multilingual, speaking multiple languages, and has a better understanding of the cultural diversity between different groups, whether it's religious or ethnic. Language and cultural beliefs play an extremely important role in the action or interaction between patients from diverse cultural groups and physicians. This is especially true in the emergency room. There are many dangers if there is a miscommunication, which it not necessarily being from the language barrier, but how the person expresses himself culturally. Often, many healthcare professionals feel they lack the power to make a difference for patients who are indigent, homeless, underinsured, or uninsured. This is not really true. As long as they're there providing the services, they are making a difference. You can't get around it. Cost is a big factor. Cost is an important factor in delaying care for patients in lower socioeconomic positions. The odds of delaying care because of cost for patients who were both poor and uninsured were 12 times greater than the odds for patients that had finances and insurance to offer the hospital. Emergency departments provide care based upon need and not arrival time. The odds of reporting delays in care among patients who were Black, poor, uninsured, or without a regular physician and did not have a true emergency were 40 to 80% greater than those for other patients. Access is really the defining issue for both safety net providers of healthcare and safety net populations. Patients who use the safety net disproportionately use the emergency department for their healthcare needs. These patients are sometimes uninsured, Medicare only, patients without a regular source of care or physician, and vulnerable populations such as the homeless, illegal immigrants, mentally ill, persons with HIV and AIDS, etc. We're going to focus on those populations that use the emergency departments for primary health care. And one of those populations is the homeless. On any given night in the United States, some 550,000 people or more experience homelessness, and this includes tens of thousands of children and chronically ill adults. Homeless people who contracted COVID-19 in the last year were 30% more likely to die than those in the general population. And in Los Angeles County, homeless COVID-19 patients were 50% more likely to die. So let's take a look at the life expectancy in the United States, comparing the homeless population, the Black population, the white population, and the Hispanic population. And you'll notice that we see that the Hispanic, white, and Black population vary for a few years. 72.6 for the Black, 80.6 for the Hispanic, and 78.1 for the white. But the homeless, no matter if they're Black, white, Hispanic, or whatever ethnicity, The average death is at 45 years of age. If we take a look down below, we can see life expectancy in the United States at 2010 data, and we see that the average life expectancy for a female is 85 years, and the life expectancy for a male is 81 years. But the life expectancy for a homeless person is 48 years. Homeless people are at high risk of pulmonary disease, traumatic brain injury, HIV, AIDS, head traumas, neck cancers, and because of possibly the higher rates of smoking and alcohol and drug abuse, their expected lifespans are actually 25 years shorter than average. Health systems in the developed world are confronted with the need to provide emergent care to vulnerable populations who often have fragmented healthcare continuity and a lack of healthcare insurance. Ideally, these indigent people should have access to appropriate continuity of care and care coordination so that the emergency department does not become a default entry point into the healthcare system. Let's begin by looking at high concentrations of homeless and indigent people within the United States. And what we're going to find is America's homeless population is larger than that of any other advanced economy. On any given night, more than 500,000 people experience homelessness, and 1/3 of them are in just one state, California. Because California has the climate and it also has the resources to better take care of some of the homeless people than other areas within the United States. Medicaid is the safety net for the poor that is managed by the states. Among the homeless individuals, Medicaid was the most common expected primary source of payment for emergency room visits at teaching hospitals. But no insurance coverage was most common among ED visits at non-teaching hospitals. Why is that? Because at teaching hospitals, remember, we have all the resources and all of the healthcare professionals available to treat anything. Whereas if you go to a regular ER, you may not have that, especially if it's a level 3 or a level 4. Here we see a graph from 2017 that delineates the sheltered and unsheltered population. And we see also how much money was budgeted to which agencies during the 2017 budget to the left. Health systems in the developed world are confronted with the need to provide emergent care to vulnerable populations who often have fragmented healthcare continuity and lack of healthcare insurance. Ideally, homeless individuals and indigents should have access to appropriate continuity of care and coordination so that the emergency department does not become a default entry point into the healthcare system. Unfortunately, we have found that the emergency department is the default entry point into the healthcare system for this group of individuals. Factors commonly associated with individuals' receipt of non-urgent medical care in the emergency department include lack of health insurance, lack of transportation, lack of a telephone, poor access to primary care, inner city residence, minority status, alcohol and drug abuse, and mental illness. These factors may contribute to both the high rates of emergency department use seen in the homeless population and to the association between homelessness and the repeated use of the emergency department. We have changed our attitude. It used to be treat them and street them, get them in and get them out. Now we are trying to take care of the indigent and homeless and provide them with some continuity of care and some meaningful medical services. Ambulance services are not cheap. What we do find with those people using the emergency department for their primary health care is that they are more likely to come by ambulance because either they do not have transportation or the bystanders that observe whatever happened, the trauma that happened to them, call the ambulance to help the homeless person. Very simply, homeless persons are at a higher risk for requiring emergency department services because of the higher rates of poor health status and higher rates of morbidity within the homeless community. Indigent and homeless people that use the emergency room or the emergency department as their primary health care source often are indistinguishable from other patients in the emergency room setting. In addition, the homeless persons usually do not go to the emergency room until after they need treatment. Many times this treatment is after a true emergency and therefore more time-consuming and costly. Hospitals are also attractive to members of the transient population. Maybe they just want to get inside from the cold weather and get into something warm. Stairwells and parking lots are good places to keep warm. Others may be looking for drugs, cash, food, or clothing. Perhaps they want to use the bathroom to bathe. Hospital staff must also be mindful that a transient who enters a hospital for non-medical reasons may become a patient if the staff discover he or she is ill or injured. Hospital employees must deal with people who are tired of sleeping on the streets. These people know that a call to 911 saying that they have a chest pain will bring an ambulance that will quickly whisk them away to a hospital. There, for a few days, a homeless person can clean up, be fed, and sleep in a real bed with clean sheets. Homeless people have a higher rate of hospital and emergency department use than the general population, and often suffer from serious conditions upon admittance, resulting in higher medical costs and potentially longer stays. Care for the homeless and the poor in the emergency department is different than care for trauma victims or people that are there for true emergencies that are just sick. The goal of social emergency medicine is patient intervention both before and after they become medically and socially complicated frequent visitors. We used to call them frequent flyers. The idea here is that these people jam up the emergency room and actually cause a slowdown in healthcare provision to people with true emergencies. We need to address this situation. The homeless do make up a significant portion of the indigent population. And what we found is in 2021, in the homeless report, we found some key facts. First of all, when compared to 2015, all of a sudden we had an increase in the unsheltered homeless that has wiped out about 10 years of work in trying to get these people shelter. We also find that we had over 209,000 individuals not living in families with children who also were unsheltered in 2020. In other words, they weren't couch surfing, they weren't living with friends. This is a record high number. Again, think about the chaos in the United States today, 2022, and the cost of living and the cost of rent, and you're going to find that there are a lot of people today who worry about being homeless that didn't worry about it just last year. Thank you for your time and attention. Again, this series was dedicated to the radiographer, whether they be an experienced radiographer or a radiography student, to look at the disparity in the use of healthcare and healthcare services in the United States. Thank you once again, and we appreciate your time.